For those who don't know, Dr. Elsebaie is a professor at Cairo University, and we're lucky to have him for some time for us at San Diego. And he will share his experience in more complex spinal issues that he's very expert on. So, Hazem, please go ahead.
Thank you, Dr. Akbari. Can you see my screen? Or not yet?
Yes, I can see it.
Yes, we see.
Okay. Okay, I'm going to discuss the strategy for surgical treatment of neglected spondylodiscitis, which I believe is much more where I practice, which is Egypt, as Dr. Akbarnia mentioned. The main difference between Europe and the USA regarding this subject is the organisms. We share the same bacteria. Most of them are gram-positive and less gram-negative. But in the West, you don't see much of TB. I believe in Middle East and North Africa, not less than between 30 to 40% of our patients are TB patients. And we used to see them more. Now they're less, but I don't think it's less than 1/4 of each patient I see having spondylodiscitis. You can see this picture of a cold abscess. It's a huge one, starting from the upper lumbar spine and going down to the femur. And that's the hallmark of TB, really. The fluid, it's not as thick as in pyogenic spondylodiscitis. And if you see a big abscess like this, which is very, very rare, you know it's TB. Most of TB now are what we call dry TB, so you can't really differentiate much between it and the pyogenic infections. The second is the age. Here, the age, I mean, more than 60% of the patients are 70 years and old. In Egypt, I believe it's half and half. Maybe like 50% are less than 60 years old. Regarding the site, the levels, it's been like that for ages. Most of the spondylodiscitis, luckily, are in the thoracic, thoracolumbar, and upper lumbar, 80%. Only 6% are in cervical and 6% in lumbosacral. And luckily, because the surgical treatment of cervical and lumbosacral is a bit more difficult. So why I thought sharing the experience in spondylodiscitis is really important. I think it's everywhere. It's a rare disease. Now it's much more. It's 14 per 100,000. So there's no much publication as many other spinal issues. It's very serious. Mortality between 2 and 20%. And if the organism is tough, it can be like 30%. Neurological deficit between 10 to 20%, which is really high. There are so many presentations regarding the level, cervical, dorsal, lumbar, the pathogens, presence of neurology, presence of structural loss of the vertebrae, deformity, is it single or multiple, is it de novo or post-operative? And with all these presentations, it's very difficult to have a recipe or a protocol for the treatment. So it's really like personal or approaches. And that's why I call it strategies. Most of the time, the diagnosis is delayed because of the lack of specificity of symptoms. It can be delayed up to 6 months. And what's really affecting the prognosis is the rapid progression and the devastating sequences if not treated. I really developed an interest in spondylodiscitis since very early. At the start, it was like obligation. It's not a popular surgery, so I had to do it. The second thing is that I always believed that the success of conservative treatment in the literature is overstated. It's always ranged between 80 and 90%, and I don't believe that this is, at least in my practice or where I work, is true. Most of the cases I used to see is neglected cases, so there is no conservative option. I had to operate. And with time, I realized that it's really rewarding. So it became an interest of choice, not obligation. And it's rewarding because the difference between patients when you see him post-operatively and pre-operatively, it's really amazing. There are many recoveries in motor deficit, unlike other specialties in spine. And the natural history, if you leave these patients, it's really disabling. Other than that, I like the anterior approaches. I feel it's true surgery. So regarding the diagnosis, you have to have a high index of suspicion. If you don't have it, probably it's very difficult to diagnose spondylodiscitis except the post-operative cases. So if you have a patient with recent back pain and severe back pain, and this patient is diabetic, on steroid, immunodeficiency, coming from certain countries, a small kid, then it jumps into your mind that it might be spondylodiscitis. The type of pain, it's a mixture of mechanical and inflammatory. So the course is progressive. As we said, it's really disabling. When you see the patient coming to you and you examine him, you feel that there is no position that gives him really good relief. And you keep pressing on him in the question to see the type of pain. He would tell you that this is really different than anything he has seen before. And it's really different. The pain is so disabling. There's local tenderness, which is very important in spondylodiscitis. Sometimes they can't lie prone, so you have to put them on the side. And there is severe guarding. So if you examine them while standing, the muscles probably will keep the spine straight, so this test will not be that efficient. Surprisingly, it's everywhere written that constitutional symptoms are present. I don't see them much, and maybe that's because the pain is so overwhelming, so the patients, they just mind about the pain. They don't mention any other symptoms. What are the important investigations? CRP is the first because that's only the start of a long journey. So you have to have a baseline for it. It's important for the diagnosis. Glycated hemoglobin is important because diabetes is one of the missed factors. Many patients would come with spondylodiscitis and then they didn't know that they're diabetic. Blood culture is very important because defining the organism is not an easy ride, and it should be done in an ideal world before antimicrobial, which doesn't happen actually many of the time because the patients come to you having already antibiotics. We do plain X-ray. MRI is the most important, and sometimes it's really difficult to differentiate between very mild degrees of infection and degeneration apart from very small fluid in the disc or festooned like degeneration of the end plate. And contrast is important in these cases. I never do surgery before doing CT because I want to know the extent of destruction, where's the defect, what's the geography of the vertebrae, so I can plan my screws and I can plan where do I approach the spine. CT-guided biopsy, I used it a lot when in doubt about the diagnosis, and if a decision is made to go for conservative treatment and we don't know the organism yet. I mean, everything is multidisciplinary, but here it's true multidisciplinary. I mean, you can't manage spondylodiscitis without having a team. An orthopedic surgeon, microbiologist, infectious disease specialist, pathologist, and a radiologist. And I use lots of the expertise of interventional radiology with me. Sometimes we just decide to go in and like drain an abscess when surgery is contraindicated. So that's in the back of my mind always. I am an advocate for surgical treatment. I am biased. And I'm going to tell you why I'm biased. I only use conservative treatment in very early cases, and I mean very early, and when surgery is contraindicated. I believe that the success of conservative treatment, as I said, is overstated. And in a recent paper, they mentioned that additional surgery is required in 22 to 55%, which is a lot compared to before. The organism is difficult sometimes to know. Blood culture less than 50%, even with no antibiotics. Resistant bacteria 13%. Conservative treatment is cumbersome. Failure may have serious consequences. Early cases, you treat them conservative, but if you treat them surgically, they have excellent results. Be aware of the rapidly progressive cases, like in children and in cervical spine. And in many times, the intraoperative finding, when I go in, I find it's worse than the imaging. This is just an example of how progression can happen in cervical spine. Between the two MRIs, there is 3 months, and you can see the difference between 1 and 2. So if you go for failure of, if the conservative treatment fail, it might be disastrous as well. So my choice has developed over the year, but mainly it's anterior debridement, graft, and anterior instrumentation. I add posterior instrumentation or do it without anterior if anterior is not feasible or contraindicated, if there's neurological deficit requiring decompression with significant deformity, multiple levels, and in osteoporosis because the vertebral screw anteriorly will not hold well. I combine both in many times. And all the single stage patients I do, I inform them that there might be a possibility for a second stage, just to keep the door open. Why would I choose anterior graft with instrumentation? Because obviously it's the site of the pathology. You can do debridement graft under vision, fast lavage, and antimicrobial powder. I use them all the time. And no need to expose the dura if it's not indicated. Anterior instrumentation, I always instrument anteriorly if I can. It's really simple. When you have this exposure, it's only 2 screws or 3 screws and you're done. It takes probably 10 minutes. No graft dislodgement. The graft is under compression, so I believe they will heal well. And you can do surgery all in one stage, and you can correct really mild and moderate kyphosis, not significant kyphosis. Some technical tips that I learned over the year. The position of the patient is really flexed, lateral decubitus position, and the bend, usually I try to make it at the level of the discitis to open the space. The most important trick is to go only to the cavity. Don't try to dissect around it and expose the anatomy. Probably you will injure something. So go for the cavity, work from within the cavity, keep yourself inside the cavity outward. Do your debridement from within, not from out. If you have adherent tissues, just leave them alone. You'll never be radical. Use very small curette to keep the bone stuck for your screws. Put the screws first before anything so that you can get the proper orientation of the vertebral body. I use ribs most of the time. They might have a bad reputation. I don't see that at all. I think if you use the posterior part of the rib, it's rounded, it's hard. You put multiple struts, the convexity of them anteriorly, and the main trick here is how to cut the rib. Cutting the rib is a very important tip because you crash it when you cut it. I have a special holder which I developed with time, very simple, just to hold the rib without crushing it. I use loads of manual push to open the space and to correct kyphosis. I insert the graft with the table flexed, then I straighten up the table so I can squeeze the graft and it hold in place. And always do cultural sensitivity and histopathology because histopathology is really important for detecting granuloma, which might not be the case here, but always do histopathology. I'll just show you some example of what I discussed. You can see that the window here, it's only at the level of the debridement. I don't expose anything outside. That's posterior, and that's anterior, and that's the space. Sorry. The second is the rib. You put the rib while the table is bent, and then you straighten it and put your rod. This is the intraoperative of this case. She's 58 years old. She had a thoracic abscess, and you can see only with anterior instrumentation, there is very good correction of kyphosis. A rib and instrumentation, no posterior. Here's the picture of a CT 1 year after surgery, and you can see how the rib is becoming part of the fusion, very solid fusion, maintained correction. And that's not uncommon. That's the usual of this procedure. This is the boy, 18 years old, no comorbidity. He came with a myelopathic gait, spastic gait, and he was starting to develop neurology. And that's his MRI, and you can see that there is one body which is already gone. If you look carefully, you will find that these are the facets. On one side, no pedicle. On the other side, just a remnant, and the body above and body below are eaten up. So there is really a big defect. That's what I've done. I didn't instrument anteriorly because it was too long instrumentation. I don't think it was really necessary. I've put two rib, corrected the deformity, and the X-ray on the right side show you how it's really well fused. Again, this is the CT. You can see the ribs, how they're like forming a new vertebral body. And on the right side, you again see the ribs. I don't expose anything except really the abscess. That's the last case I'm going to show. She was a small girl. I operated on her doing L1, L2 fusion, and we thought it was TB. We realized she had fits second day post-operatively, and when we have done an MRI spine, we realized that MRI brain, we realized it's a fungal infection. She came after a year with this severe junctional kyphosis, but at the level above, at D11, D12, and that's her CT scan showing the previous surgery very well fused, but unfortunately, she developed this horrible junctional kyphus. I didn't go anteriorly. I just did a posterior instrumentation, and it's used. And on the right side, you can see the both fusion mass at the level below and the level above. And the difference between the first MRI, this one it was in March 22, and the second is in July 22. So in just few months, you can see the amount of fusion. Thank you very much. Any questions?
Thank you, Hazem. It was a very great presentation. One question I had was on, trying to use different grafts or cages and so on. You mentioned that you always use ribs.
Yes.
Any thought on using allograft or just interbody cages or just corpectomy cages and so on? What is your experience on that, and what's the usual recommendation?
I tried to use allograft at the start, but I didn't have really good results in the way of fusion, and I stopped using allograft. But cages, I use lots of cages, mesh cages, and but with autograft inside, and I use them when there is no access to ribs. So for a Moss cage with autograft, I used it in cervical spine, in lumbar spine, but allografts, I don't favor them, Dr. Akbani. I don't feel that with the infection and with the devitalized tissue in my hand, I don't think they give me the same results as the autografts.
Yeah, it seems that there might be some difference between TB and acute sort of pyogenic infections, and maybe there is some difference between those two types of using allograft or autograft. But yeah, that's interesting. Any other questions?
Yeah, I have a question, guys. Baruch.
Yes.
My name is Kevin Yu. I'm a neurosurgeon in San Diego. I'm just curious as to what you guys have available in Egypt. I saw your instrumentation. You talked about the cages. First, tell me what are the instrumentations you use in those cases? What do you have available in Egypt to you? And I believe the patients are responsible for paying them, right? So does that make some obviously limitations on what you can do surgically? Just curious about your situation in Egypt.
Can you tell me the first question, instrumentation. The second is?
Patients paying for the instrumentation. Do you guys have
paying?
Yeah.
Yeah.
Do you have a robust insurance plan that pays for the instrumentation, or is it the patient paying for them?
No, instrumentation, we have everything really. I personally prefer the side loading system. I still use a side loading. I like the posts of the side loading, but we have Medtronics, and the instruments are really available. They're available in private and they're available by the government. So we don't have a problem in instrumentation. It's a choice of surgeons. I don't think instrumentation. I work in Cairo. I work in Cairo University Hospital and in another big hospital, which is called Nasser Institute, a big spine center. So for me personally, there's no issue with instrumentation. Probably maybe in remote areas they have, but I don't have this problem currently.
How about the use of infused then? If you have Medtronic metal, do you have Medtronic biologics?
No, we don't have Medtronic biologics.
I see.
No.
So the patients don't have to pay for their instrumentation. You have an insurance plan that's very strong that covers these very expensive surgeries, right?
They cover instrumentation, but not biologics. The
Mm-hmm.
biologics are not there really.
I see. Okay, very interesting. Thank you. Thank you.
Pleasure.